the head of Provincial Health Office, Central Java, the head of Semarang City Health Office, our distinguished guest lecturer, Professor Charles Ameh, our honored lecturer, Dr. Ratnasari Dwi Cahyanti, obstetrician and gynecologist, professors of Faculty of Medicine from Universitas Diponegoro and also from our university partners, lecturers, and then also the students from the Faculty of Medicine, Universitas Diponegoro. Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. Welcome to the guest lecture of the MPDSR series, How to Use the Clinical Standard for Objective Review in Maternal Audit. How are you today? All right, first of all, let me introduce myself. I'm Nana, and I will be the master of ceremony for this afternoon lecture. Ladies and gentlemen, in today's lecture, we are very honored to have Professor Charles Ameh as the guest lecturer from the Liverpool School of Tropical Medicine. However, before we start the opening ceremony, should we pray all together so the program will run well? Pray start. Finish. Let us start the opening ceremony today. As the host of this lecture, the Dean of the Faculty of Medicine, which is represented by the head of the Department of Nursing, will be delivering the speech as well as opening the guest lecture. Dr. Anggorawati, maternity nursing specialist, you might take the floor.
The Honorable Professor Charles Ameh, PhD, and the Honorable Dr. Ratnasari Dwi Cahyanti, the Honorable participant, we know for Hotsi, Pogi, and others, and the participant in this morning. Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillahirabbil alamin. My sincere gratitude for the opportunity given by the Almighty, so that we all can meet together in this special meeting. This event is part of the summer course with the theme Global Maternal and Child Health, setting priorities based on evidence to innovation solution. And it's part of a series of activities for the 62nd anniversary of Faculty of Medicine, University Diponegoro in 2023. Guest lecture title is How to Use the Clinical Standard for Objective Review in Maternal Audit. And we very thank you for the Professor Charles Ameh. He is the co-director WHO Collaboration Center for Research and Training in Maternal and Human Health, and is the Deputy Head International Public Health Department, Liverpool School of Tropical Medicine. The purpose of the guest lecture, so to enrich the sharing knowledge about the clinical standard for objective review in maternal audit, and in this forum, we know the specialist resident, the doctor, and the nursing, and the other school, I think. And the topic about maternal and perinatal death surveillance and response is very relevant to the Indonesian condition, especially in Central Java. I think this is a topic very, very urgent for all. My name is Anggorawati, and I is head of the nursing department on behalf of Faculty of Medicine, Universitas Diponegoro. And I would like to say that it is our privilege and pleasure to have the guest lecture. We say Bismillahirrahmanirrahim. I officially open the guest lecture, Global Maternal and Child Health. And I hope this event will run successfully. And I would not like to take too much of your time, so I will hand it over to MC. Once again, welcome and thank you very much for attending this event. Assalamualaikum warahmatullahi wabarakatuh.
Assalamualaikum warahmatullahi wabarakatuh. Thank you very much, ma'am. It was a delighting speech from Dr. Anggorowati. Ladies and gentlemen, now we'd like to have the lecture session begin. The guest lecture will be held for about an hour and a half and is divided into two sessions. The first session will be the presentation session and then the discussion, question and answer session. The participants, you can ask directly or you can type. For the online participants, you can type on the Zoom chat for the question that will be asked to the our lecturer today. And I'd like to invite our moderator for this guest lecturer. Our moderator is Dr. Ratnasari Dwi Cahyanti, specialist in obstetric and gynecology. She took her PhD in the Faculty of Medicine, Universitas Gadjah Mada. She is one of our outstanding lecturer, and she has so many publications and also academic or scholarly works. And she will lead the guest lecture today. Dr. Ratnasari, please welcome.
Good afternoon. Assalamualaikum warahmatullahi wabarakatuh. Thank you for all the participants to attend this guest lecture that we have a special distinguished guest, Professor Charles Ameh from Liverpool School of Tropical Medicine, that this lecture will be done with the topic how to use the clinical standard for objective review in maternal audit, as in our country that maternal audit is not a it is a common that we done in the district level, and also maternal debt review has been done as a facility maternal debt review. But one of the key point in this case that in Indonesia, we still have the same challenge. What the same challenge? Until right now, we still trapping in the same preventable maternal death. So actually that maternal death review, if there is been done objectively, it can be as an evidence-based solution. So one key point that Professor Charles Ameh and his colleagues has been identified that that in developing countries, in low middle income countries, that using a clinical standard is not done properly as the framework during maternal death review process. Before starting the guest lecture, I would like to present the CV from Prof. Charles Ameh. Yeah. As the Master of Ceremony stated before, that Prof. Charles Ameh from Liverpool School of Tropical Medicine, that he has an incentive research in maternal death surveillance and response, and also he took some responsibility in WSO as technical. Sorry. Yes. Yeah, one of his position right now is very important in as a WHO Technical Advisory Group on maternal mortality and maternal cause of death estimation, and also global maternal and perinatal death survival and response technical working group. Please, Prof. Charles Alme, you can come to the stage. Yeah. Yeah, Prof. Charles Alme, you have 50 minutes to present about what the main topic that we would like to discuss in this afternoon. Please, the time is for us.
Thank you. Thank you very much for the kind words and introduction. I'm very happy to be here to share some of my experience over the years conducting research, implementation research, to try and improve the quality of care for women and newborns. So I'm very happy to be in Asia, in Indonesia, and I'm very grateful for the warm welcome received. Are you able to share the slides I have? Can I see them? So I'm going to use a set of slides and maybe speak for another 40, 50 minutes. And then, we can have a discussion. So I'll be talking about how we can use clinical standards, a process of clinical based audits as an objective way of performing maternal debt reviews. Next slide. So just to remind us, why is this topic important? So we know the latest reports published by the WHO about the trends in maternal mortality between 20,000 and 2020. Unfortunately, almost 290,000 maternal deaths were estimated to have occurred in the year 2020, giving us a maternal mortality ratio of 223 per 100,000 live births. So the risk of death during pregnancy and childbirth is still too high. And most of these deaths are occurring in the least developed countries, with sub-Saharan Africa accounting for about 70%. The maternal mortality ratio in East Asia and the Pacific is about 75 per 100,000 live births. But we still have up to 8,000 maternal deaths per annum in Indonesia, with an MMR of about 179 per 100,000 live births. So this is why we are discussing, ways of improving the quality of care and reducing risk to death during pregnancy and childbirth. Now, I took this table from the latest report from the Ending Newborn Deaths and Ending Preventable Maternal Mortality Deaths Progress Report from WHO, published in June this year. And you can see that Indonesia is amongst the top 10, 12 countries where most of the maternal deaths are still occurring globally. And this will be because of the population, of the country. So we still have up to 8,000 deaths. And if you combine maternal deaths, stillbirths, and neonatal deaths, this will come to about 103,000 deaths. So this is a lot of deaths. So the question is, how do we reduce the risk of dying during pregnancy and childbirth? Now, a lot of you know about the Sustainable Development Goals. You know about the MDGs. So these targets were set on these goals for reduction of maternal mortality ratio. So in order to meet this target, we need to have a rate of annual reduction that is sustained to be able to meet those targets, or otherwise we cannot meet those targets. So the global target for maternal mortality ratio by 2030 will be 70 per 100,000 live births. but no country is expected to, have maternal deaths above 140 per 100,000 live births. So even if we use the 140 per 100,000 live births, you can see that the rate of annual reduction required is quite significant to be able to meet that target. So we're midway into the SDGs, about 7 years to go. And that's why we're having this discussion today. What can we do to accelerate progress? Yeah, I'm struggling to move my slides. Now, let's go back in history and let's see what can we learn from, the trends in maternal mortality reduction in countries over the years. So I take you back to the obstetric transition model, which was published just before the end of the MDGs, 2014, and looked at, the trends in maternal deaths over several years. In most of the countries globally. So in this model, they described 5 stages. So if each stage will define the approximate number maternal mortality ratio, so where stage 1 will be more than 1,000 per 100,000 live births, stage 2, 999 to 300, stage 3, 299 to 50, stage 4, less than 50, and stage 5 less than 5. So if we observe different parameters, how they change when countries move from one stage to the other. So total fertility rate represents the average number of babies a woman in the reproductive age will have. And still the proportion of births attended to by skilled birth attendants, SBA, is another parameter we are looking at. The proportion of women giving birth in healthcare proportion of women giving birth in healthcare facilities is another one that we're looking at. And then we're looking at the causes of maternal death. So we're comparing we're talking about direct causes of maternal deaths, indirect causes of maternal deaths. We're looking at communicable diseases and non-communicable diseases. In terms of medicalization of births, essentially what we can use the proxy indicator for proportion of births where you have a cesarean section, for example. And then, overall, we talk about when do we need to focus on quality to bring about further reduction in maternal death. So let's walk our way through these parameters across the various stages. So total fertility rate decreases from very high mortality to very low mortality. So essentially, you need to increase contraceptive prevalence rate, family planning, in a population to help reduce the rate of maternal mortality. So I don't think that's too much of a problem in a country like Indonesia. The proportion of women who attended to by skilled health personnel, you all know what that means. A trained, medical personnel working within a team to help look after women during pregnancy, childbirth, and in the puerperium. So as this will increase as you move from very high mortality to low mortality. And this will be consistent with the proportion of women delivering in healthcare facilities. So what I want you to observe is that, so this in stage 1 and stage 2, this is very low or low. From stage 3, it is above 60%. And by the time we get to stage 5, almost every woman in the population is giving birth in the healthcare facility. In terms of the causes of death, so we move from direct causes of death. So just to remind you, when we talk about direct causes of death, we're talking about hemorrhage, eclampsia, sepsis, complications from prolonged obstructed labor, and things like that. To non-communicable diseases. So we're looking at hypertension, obesity, and all those kind of chronic conditions. So with very high mortality, hemorrhage, infection will predominate. And as we go down to stage 3, we start having more chronic diseases contributing to mortality. And by the time we get to stage 4 and 5, direct causes of maternal mortality are not really a problem in such countries. In terms of medicalization of births, I mean, if you can remember historically, before the advent of antibiotics, safe surgery, you know, a lot of women who were obstructed, had an obstructed labor, you know, they have a very poor outcome. If you had to have a cesarean section in those days, it's a death sentence. So baby may be saved, mom will not be saved because no blood transfusion, no antibiotics, you know, and all of that. So no surprises. When we had very high, in countries where you have very high mortality, C-section rates are low. So that's what this tells us. And by the time we have reduced significantly to say less than 5 per 100,000 live births, the trend we tend to see is over medicalization. So we have now too much cesarean sections, a lot of unnecessary C-section. That is what happens. But the take-home message here, let's look at what happens. What do we need to do to further reduce maternal mortality when we get to around a rate of between 299 to 50? If we do not improve the quality of care, we will not reduce that further. So that is one area where we need to focus. And that is where probably from the statistics I've shared, where Indonesia is now. So it does need to focus on quality of care. Next slide. Right. So what do we mean by quality improvement? So this is a systematic data-guided activities designed to bring about immediate improvements in healthcare delivery in particular settings. So I want to emphasize that this is data-guided. There's a reason why, you know, it is data-guided. So it needs to be quite objective. It needs to be objective. It's not based on feelings or, you know, eminence. It has to be objective. So you find out objectively what the problem is, and then you solve it, because that is precision. You know exactly what you're not doing right, and you know what to improve. So this is the whole concept of quality improvement. So quality improvement it has to be systematic. It needs to be a planned approach to monitoring, assessing, and improving the quality of services on a continuous basis. It's not a one-off issue. You continuously look back to improve. There needs to be a culture for improvement. So it is oriented towards meeting the needs and expectation of our clients, as well as meeting the standards of care. If we don't have women coming to deliver in our facilities, we essentially have no job. If you come to work and there's no woman to see, you come, you tell stories, have your lunch, and you go home and you get paid, you should be upset. You know, it's a disservice. You're not doing anything. So you want to meet the needs of women. If women are not coming, why are they not coming? You may need to talk to them because you need their inputs to provide them better care, a care they will enjoy, they will have respect, they will have dignity in that care. But at the same time, you want to provide them evidence-based care, the highest quality of care. There's no reason why a woman in one country should have one level of care different from a woman in another country. It's the same biology. They're not different. It should be the same quality. Focus, we need to have this sort of care based on our understanding of the process of producing care. We need to be able to employ standards and benchmarks and guidelines or client expectations to ensure that we have an acceptable level of quality. So, for example, the WHO says, you know, based on evidence, this is the highest level of evidence. This is how you should provide care for women with, say, postpartum hemorrhage. I mean, a country cannot say, you know what, our women, they're not, we need to do something different, something lower. No, it's the same woman, the same biology. So we should strive to meet that standard. That standard may be adapted, modified with the guidance of the policymaker in the country, the Ministry of Health, the professionals, obstetricians and midwives to develop standards. So those standards should guide practice. So we should, as part of quality improvement, we should look back from time to time to say, you know, are we meeting those standards? What proportion of women that we see for this particular condition are meeting those standards? Now that is objective. That way you can pinpoint where you need to improve your training, you need to improve your practice, what you need to do in terms of supervision to raise the bar to produce that sort of level of care. So it really underscores the use of using data to improve, to measure performance and practice, and then for improvement and purpose. Now, I think nowhere in medicine it's more important than in obstetrics, where multidisciplinary team approach is important. One cadre of staff alone cannot manage a pregnant woman. The midwife has a role, the obstetrician has a role, the ancillary staff has a role, the anesthetist has a role. So it's a whole team approach. And, I think this is also part of quality improvement. So there are several terminologies you will come across: quality assurance, and then quality improvement. For academic reasons, we can talk about the differences. Quality assurance will involve checklists, benchmarks against which performance is sort of evaluated. And typically you can do this externally. So somebody who is not involved in the process can come in and do this. And some people say, the more external input you have, the more objective the process is. But then you can argue that so long as we're using a checklist and if everybody remains professional and truthful, we should have the same result, isn't it? But then when we look at quality improvement, there needs to be an understanding of the process as well. And then that involves a commitment to correct things from within. And when we talk about a continuous process of quality improvement, you want the ownership to be within that system where you need to improve the quality. If there's leadership at that level, then that approach will be sustained and it will be continuous. In my definition, I talked about the need to have a continuous process. So I think having a quality improvement mindset is critical. So I'm just going to mention some of these. A lot of you know about it. So the quality improvement circle, you need to plan, define exactly what you're doing, be able to monitor. Because you understand the process, you can make improvements, and then you evaluate those improvements you have put in place. So this is quite important. If they are not working, you make adjustments, and then you go again. So it's a continuous process. And just for definition, we need to define what the problem we want to improve. Okay, so for example, we can say what we want to improve is the management of postpartum hemorrhage. I'll pick postpartum hemorrhage because it's the commonest direct cause of maternal deaths. So we want to improve management of postpartum hemorrhage. This is a standard. So we choose the standard which is available for that. Okay, from the Ministry of Health. It has guidelines for example, managing patients with postpartum hemorrhages. Now, we want to collect some baseline data on what compliance there is to that standard. We want to look at some of the contextual issues around that. When you do when you measure against standards, you don't stop there. You might want to look for, conduct some other studies, collecting information from clients, the pharmacist, everybody involved to understand something. Say, for example, the Ministry of Health says that every woman that comes with, in labor should have oxytocin for the prevention of hemorrhage. And for women who actually have postpartum hemorrhage, they should have oxytocin infusion. They should get a senior obstetrician to review them within 30 minutes. If you review all the women who's come to deliver in your unit within a certain period of time, what proportion of them meet that standard? If you find out that the proportion of them meeting those standards is low, you want to ask yourself why. So the reason why they may not be getting that oxytocin may be because, every time you want to use oxytocin, somebody needs to run to the pharmacy to get the oxytocin. A solution might be, okay, you know what? All the oxytocin should be in the labor ward. And then you make an action. If you now affect that, the next time you measure that standard, you expect it to improve, maybe from now 30% to 60% or 80%. So you need to be able to collect your baseline data, understand the process, put measures in place to improve the situation. Then you allow some time to reevaluate to see, how much of those improvements are taking effect. So this is that define, monitor, improve circle, which I showed you previously. So this sort of approach is all within the WHO quality of maternal newborn care approach. It's about using guidelines and standards to improve the quality of care using that MPDSR circle. Very important to bring all of this together. Now, typically in countries, WHO takes the lead. WHO comes up with evidence-based standards and recommendations. Professional bodies, obstetricians, midwives, Ministry of Health work in country to make adaptations to this. And then, they train healthcare workers how to implement these standards. So that's what usually happens. Now, there's several quality of care indicators that have been proposed from the Every Newborn Action Plan and Ending Preventable Maternal Mortality recent report published by the WHO. And, these indicators are indicators that can be adapted, within your centers in the countries, in various countries. And, this is a good way of also measuring, quality of care. And then you can measure what it is, put interventions in place, and then you measure after some time to see how you're progressing. So by adopting some of these indicators, it means that you can compare between countries in the same region. If we're all measuring the same thing or different centers, you can see how much you're doing, how good you're doing, and where improvements need to be made. So let's focus on, I know I've probably jumped into this already, but let's just run an overview of quality improvement methods used for maternal and newborn care. So there are several that you find in the literature. I've listed them here. I'm not going to talk about all of them. I will just spend my time talking about the first and maybe the second to the last in this list. But just something to note. Confidential inquiries into maternal deaths, just to make a distinction, why they are different from maternal death reviews. Maternal death reviews they usually occur at healthcare facility level. They will involve the review of women that die, during pregnancy and childbirth, usually by the team that has provided care. And this team will come up with what factors can be avoided, what they can do differently so that, a similar case in future, death will not happen. So that is what this should be all about. Now, this needs to be carefully managed. Otherwise, we will be coming up with recommendations that will not make a difference, okay? If the atmosphere for these reviews are not transparent, there is an atmosphere of fear, of shame, and blame. What it means is that what is coming out will not respond to what the need is. If there's fear, blame, and shame, the quality of the data available for review will be poor. I give you an example. So you have a system in a country. I will not call the name of the country, but you may identify with this. You have a system in a country where if a death occurs at healthcare facility level, it is notified through the health management information system. So the headquarters, the Ministry of Health, we know that for facility A, there have been 10 maternal deaths, okay? So the Ministry of Health says, okay, we want to do a central review. We send somebody to the facility to collect all the records for the 10 patients. But they get to the facility, you can only find 5 records. Suddenly, 5 have disappeared. They have disappeared because maybe people are afraid. Maybe I will be blamed, I will be shamed, so it disappears. In other cases, some pages in the record have disappeared. In other cases, the pathogram was filled retrospectively. They filled it in such a hurry that they even put the date after the woman died. They plotted the so these are some of the things that happen, but it happens because people are afraid. Now, in confidential inquiries, it's a sort of maternal debt reviews, but it's done by people who were not involved in the care. It's more anonymous, it's confidential, there's no identifying feature, so people can, review these debts more objectively. So if they come out and say, this is the cause of death, these are the avoidable factors, most likely that is what it is. That issue of fear, blame is not there. But confidential inquiries are not as agile as maternal debt reviews. What do I mean? A confidential inquiry into maternal debt, at best, even if it is prospective, it is a few months back. What typically is 2 years, 3 years back, and is looking at all the debts that have occurred in a region or in a country. Although it is very efficient in providing evidence of where improvements can be made, how it can be linked to developing policy guidelines, improving training, and all of that. But, those actions will come sometime later. Whereas in the facility, you can, find out what are those actions that are immediate, that we can improve immediately in the next few weeks, in the next few days. You can get that information there. But that is only possible if the review is done based on evidence. If it is based on emotions, and you did this, you did that, shame and blame, you're not going to get any results. You cannot have the results we were talking about. So that is all I just need to emphasize on at this point. So maternal debt reviews are described as qualitative, in-depth investigations of causes and circumstances concerning debts around the maternal debt. And you can have facility-based or community-based. Historically, we know about the whole concept of maternal debt reviews, which is well described in the publication Beyond the Numbers. But then, after implementing this for so many years, one thing became evident. In countries where you don't have a lot of facility-based deliveries, we were missing a lot of women. We're not learning from women who die in the community. So in terms of surveillance, that aspect, counting those numbers was poor. The next thing was that, we had no documentation or evidence that these maternal debt reviews were leading to either improvement in quality of care, reducing the risk of death. There was no evidence. So there was a sort of rebirth of the process, making it now maternal debt surveillance and response with guidelines published around 2012, 2013. So global guidelines, and this was to try and improve on the surveillance aspect, making sure that we account for every woman that died, facility or in the community, but also that we make clear recommendations and we document the actions and the improvements as a result of these maternal debt reviews. Furthermore, the WHO went on to publish in 2021 implementation tools to help improve the quality of implementation, again, to help us solve this problem of the response lagging behind. So we're still struggling. So, so just to reiterate here, so there are several challenges when it comes to the surveillance aspect of MDSR. If you have in countries where most of the births, so women are giving birth, most of women are giving birth in the healthcare facility. So 90%, 95%, 100%, all in healthcare facilities. So if they're giving birth in healthcare facilities, if they die, they're dying in healthcare facilities. In that regard, it's easy to identify all the deaths. Okay, because first you must identify the deaths, report the deaths, and learn from the deaths. Okay, but in a country where a good number of the deaths are occurring in the community at home, if you don't have a good system, A, you will not know the numbers. B, you have no opportunity to learn from those debts. You need to learn from them to prevent further debt. So as part of a component of maternal debt reviews, we need to be able to identify the debts, make sure that all the debts are reported, and then this will help us to review all the debts, measure the quality of care, and then we come up with quality improvement measures. So those quality improvement measures are critical to the response aspect of maternal debt reviews. If we're just starting to implement maternal debt reviews, the advice is you start small and then you increase. So it's not about just scaling up and doing it everywhere, but not doing it properly. You want to be able to do it properly. That's the recommendation from the WHO. These slides will be available, so I may not go through everything, but I think the emphasis here is that, we need to follow that circle of identifying the debts, reviewing the debts properly and objectively, making smart recommendations, tracking those recommendations, and really accounting for those actions. So this is quite important in the process. Now, the question is, does maternal debt reviews, do they work? Are there challenges in implementing maternal debt reviews? So maternal debt review is a classic form of audit and feedback. We know from systematic reviews, a large systematic review, which was reported in 2012, which included about 140 publications, that standard-based audits, as an example of MDRs, they make small but important improvements, to the practice, the quality of care. Although the biggest systematic review on maternal debt review says there's limited evidence of effectiveness, but where it is effective in lowering maternal mortality, they use external MDSR facilitators during these reviews. And do you know why they use those external facilitators? Because they sort of bring in more objectivity to the process. So if you have an external facilitator and this maternal debt review meeting is deteriorating into a blame and shame and all of that, they're going to bring everything back to objectivity. Everybody take a breath. It's not about who made the mistake, who is wrong, who is right. We are all trying to learn to prevent the death of the next woman. So what does this mean? These factors were avoidable. What can we do about it? Who is involved? Who are the stakeholders involved? What action needs to be taken? By whom? By what time? Who will report back? So you come up with actions that are specific. They are measurable. They are time bound. Those are the kind of actions that you want. So when you bring in objectivity into the process, that is what you get. And then most likely you will come up with actions that can prevent the next death. You don't fall into the situation where everybody gets upset, defensive, and then you do not have any action. So let's look at what we can find in the literature concerning, some challenges and, how this can be overcome. Confusion by healthcare workers on their new responsibilities. So healthcare workers can be given directive. If we want you to notify all maternal deaths, you must review all maternal deaths, all perinatal deaths. And the healthcare workers say, you know what, we're already overburdened. There's a lot of work. They don't understand why they are doing this. So they need to understand why they are doing this, why it is part of really improving the quality of care. And you can overcome this problem by training, orientation. You have committed leadership. At times, you train people how to do MDSR, but within a short time, you deploy them. The turnover is so high. You train 30 people working in the facility. You come back after a month, only 5 are left. All they have been deployed somewhere. So what do you expect? The 20 that have come in, they are not trained. They have bad practice. Will the 5 influence the 25? No way, they're not. So they're all going to go back to square one. So we need critical mass to bring about change. A critical mass of people doing the right thing will change the behavior and the practice. So for this, we need we have committed leadership in planning. We need to anticipate problems and then, plan to mitigate this. Then there's the fear of legal repercussions. So we have cases in some countries where the MDSR process is not protected. That means it's not guaranteed that information from there will end up in the court of law. So if a healthcare worker thinks that the files or the records from the maternal debt review will end up in court, and they will call me to say, oh, you are the one who did A, B, and C. You actually admitted that you made a mistake. So you are going to prison. Well, nobody's going to take part. So in many countries, what they have done is to say, there's a law, anything that is discussed in the maternal debt review meeting, confidential inquiry meeting, it remains there. It's confidential. All the healthcare workers who take part in that process, they sign a document to say, we are not discussing this out of here. We will not use this for anything. None of this paperwork can be used for any other thing. It's a different thing. Malpractice is a different thing. There's a separate mechanism to deal with that. It's not part of the MDSR process. Now, we talked about objective reviews. If you have poor quality data, it's garbage in, garbage out. You cannot find the evidence of what is wrong. So we need good quality data. We need good quality data to be able to do that. So record keeping culture, practice, systems. Okay, even though we're using paper-based system, if you have bad handwriting, people cannot read it. If you have incomplete records, we cannot audit against standards. So we need ways of medical records, standard performers, whatever it is, to make sure that we collect accurate data. That's important. Now, there's a big problem that the debts that occur outside the facilities are not included. In this case, we need to institute community-based maternal debt review so that we capture those ones. So there's verbal autopsies and all of that. There's also, we've talked a lot about no blame, no shame. So all these are important. On the review of maternal debts, there's the validity of the reviews and recommendations. And for here, from that, this is a Cochrane review actually by Wilcox et al. What really works, they said, is the use of external MPDSR facilitators, because they really bring objectivity to the process. They help you get, that sort of focused recommendations that are actionable. And then you also need strong leadership if this is going to work. So strong leadership at national, subnational, and healthcare facility level, at all levels. What about at the point of analyzing and making recommendations? You need that similar, it's a similar thing. You need good integrity of those recommendations. So training, supervision, use of external facilitators. What about the response element? Again, with good quality reviews and recommendations, then you're most likely going to have this. Now you need strong committees that are funded. So the funding, we can look at funding at all levels. Even in a healthcare facility, you want your review committee to meet every month. They already have a high workload, but they come to meet, but they don't even have a cup of tea. As little as a cup of tea. And as little as the medical director once in a while just say an announcement, we thank these people for the good work they are doing. It's motivation. People like it. It encourages them to keep working. So that is leadership can help to prepare, to push people on, because this is very important work. Also, those who are involved in maternal debt reviews, it's a lot of emotional burden. When you read those case notes, you see how women died, all the circumstances. It's something you go to sleep with. You think about it and all of that. They need emotional support and mental health support, to be able to do this type of work. So this is something that needs to be considered. So let's quickly talk about standard-based audits. So what are they? So these are objective, systematic, critical analysis of the quality of care against agreed standards of care. So again, how do we come to these standards of care? Standards of care are based on evidence. the WHO has evidence for how you manage eclampsia, preeclampsia, pregnancy-related sepsis, postpartum hemorrhage. There's all of those things. So there's a guideline development committee, a committee of scientists. They have a well-tested process of identifying the best evidence, the best practice, and they grade the evidence, grade A to E, the best evidence, and they produce these WHO documents. The Ministry of Health will take that document and use it to update their own guidelines. And when they're doing it, the Ministry of Health usually will not do it alone. They call the obstetrician, they call the midwife, they call the anesthetist, so that they make it their own. They're not changing the evidence. They're just making sure that if they say this should be done at primary healthcare, in your country, maybe primary healthcare has a specific name, they will call it that, so that it is owned. And if you interact with the leadership like that, then cascading and owning and training is easier. So that's why the Ministry of Health goes through that sort of adaptation thing, not that they are producing new evidence. Okay. So once that is done, then you have a standard of care. So the expectation is that every woman should have that standard of care. So that creates an opportunity for quality improvement. Okay. So we can do clinical audits or criterion-based audits once we have standards of care. And we can decide what the standards of care, we can make them measurable, and it can help guide our quality improvement efforts. So having said that, let me just present to you one way you can use standard-based audits. You can use them, and typically we use them retrospectively. You can do it at facility level, different level of facilities. You need to be able to institute it and make it a culture in that facility. You pick the topics. So if you look at all the maternal deaths that occurred maybe in the last 3 months, and you find out that 60% of them was due to postpartum hemorrhage, or 60%, 70% due to eclampsia, you might say, okay, you know what, the next thing we want to do, let's do a standard-based audit for all the women that died from eclampsia. So you go to the medical records, you tell them, give me the files, the list of all of that, and then you give 1 or 2 people the responsibility. Now, this is the guideline from the Ministry of Health. This is the standard that is expected for treating eclampsia. So they bring out the standards. The standards may be 10 standards. And the question is, for each one of these standards, what proportion of these women in their care did they meet this standard? And they can report back to you. So it's that simple. When they report back to you, you see what the proportion is. Then you ask yourself the question, okay, why did we not meet the standard? Then you can talk to people. Talk to the midwife, talk to the doctor, talk to the pharmacy, okay? You may find out that one of the standards for the eclampsia is that in the cases of severe preeclampsia, magnesium sulfate should be given within 30 minutes of diagnosis. That may be the standard. But you find out that of these 100 women, only 5 of them, that standard was met. So you need to ask yourself why. So it may be magnesium sulfate was in short supply, not in the pharmacy. They had to go and buy. There was magnesium sulfate, but there was no calcium gluconate, so they didn't feel comfortable to administer. So you find out why. And based on that why, you come up with the quality improvement. What needs to be done? We need to increase supply. People don't know how to give the magnesium sulfate training. So you put all of that in place. 3 months later, you do the same exercise, and then you can see how it is improving. So it's that simple to do. So in this case, we did a secondary analysis of a data set, which was used for the confidential inquiry into maternal death. So we've extracted data for all the women that died from 2014 to 2017. This study was conducted in Kenya. it was based on new WHO recommendations, so they had the guidelines in the country on what needed to be done for PPH. And, so all we did was just look at the national guidelines, look at all the standards that were expected. There were about 10 standards we picked out. And then we picked out all the cases of women that died from PPH. And then we assessed to what extent that they met this standard. So it's that simple. So just focusing on the standards now. So the standards were met for, at least 50% of all women who died for only 3 of those standards. For 50% of the women was this met. So we're looking at 8 standards, but 50% for only 3 standards of the women that were met. So this is not good enough. And those are the 3 standards there, assessing within 30 minutes of admission, whether there was bleeding, administration of intravenous fluids, administration of blood transfusion when initiated. So these were the ones that look good, but this is not good enough. We should be hitting 100%, isn't it? The least met standard is the active involvement of senior medical personnel in the management. I mean, if you're dealing with postpartum hemorrhage, it is so important to get senior obstetricians involved early because things can go south rapidly. But with their level of knowledge and experience, they can know what to do quickly, and then you work as a team. But this was the list. Now, when you investigate this, it's not because they don't have obstetricians. In fact, every referral hospital has at least 2 obstetricians. So what is the problem? Are the juniors afraid to call the seniors? You need to investigate why. And then once you address that, then you hope that the situation will improve. So this is how you use this thing. So you can check what is the compliance with the clinical standards. That's how you perform the audits. Okay, so I think I've run through the burden of maternal mortality, the importance of quality improvement, the importance of improving the quality of care, how we can use maternal death surveillance and response. One of the approaches there is clinical-based audits, which is based on checking compliance with standards against agreed clinical care standards in the country, which are usually evidence-based, and they usually draw from WHO recommendations. This is simple. This can be done. This is quite objective. And it may be less threatening or can be complementary to maternal death reviews. So I will encourage both of them to be done, in your setting. I wouldn't be so worried about the burden of work involved, because if you assign a pair of clinicians to do audits in specific topics every 3 months, it's not so much. Just when, with the supervision of a senior obstetrician or so, when they do the audits and they find out what needs to be improved, there's a discussion. You put those improvement measures in place, and then you run another cycle of measurement, and then you see how much you've improved. If you're not improving as much as possible, you investigate more and you put those improvements in place. So it's an iterative process, okay? So in summary, quality improvement can lead to better patient experience and outcomes. It relies on changing provider behavior and organization. The change is usually systematic. And you can use 1 or 2 methods for quality improvement for MNH. They are usually complementary. But I think what we're advocating for, to complement what you're doing already, maternal death reviews, you can add standard-based audits. So thank you very much. I'm happy to take questions.
Thank you, Charles, for your presentation. It's very nice presentation and open our mind, all the audience about how to build the atmosphere of maternal perinatal death and surveillance and response. Ya, jadi sebagai apa yang sudah diungkapkan oleh Prof. Charles Ameh ya, jadi pada pelaksanaan maternal perinatal death surveillance and response ya, kalau kita sekarang memakainya namanya istilahnya MPDSR ya. Nah, itu ternyata kita membutuhkan membangun suatu atmosfer yang akan mendukung untuk pelaksanaannya itu kita bisa mencari akar masalahnya secara objektif. Jadi salah satu apa caranya untuk mencari akar masalah yang objektif itu adalah dengan membangun suatu atmosfernya ini adalah free blame culture. Itu yang pertama yang harus dibentuk. Sehingga nanti di situ kita akan bisa mendapatkan suatu akurasi data yang bagus. Kemudian yang kedua, ketika sudah mendapatkan akurasi data yang baik, kita berikutnya adalah bagaimana melakukan kajian yang objektif. Nah, salah satunya di situ ditekankan sekali oleh Prof. Charles Ameh, yaitu mengenai kajian objektif ini, mengenai peningkatan quality standarnya itu. Karena mau tidak mau sekarang ini di Indonesia, kita terjebak pada third delay. We are trapping in the third delay in Indonesia right now. Dan kalau kita terjebak pada 3 delay, itu kebanyakan adalah memang ada permasalahan-permasalahan di fasilitas. Nah, permasalahan di fasilitas ini tentunya ketika melakukan kajian yang objektif, itu membutuhkan suatu standard of care yang misalnya seperti Prof. Charles sampaikan tadi ya, contohnya adalah pada kasus postpartum hemorrhage ya, perdarahan postpartum di situ beliau dengan tim sudah melakukan penelitian berdasarkan kasus-kasus kematian ibu di manakah didapatkan titik-titik minimal standar yang tidak bisa dijalankan dan di situ perlu perbaikan. Dan dari Prof. Charles juga menekankan bahwa kita itu adalah pada permasalahan sistem, tidak bisa hanya bertekan pada permasalahan individual. Jadi tadi seperti disampaikan beliau, belum tentu itu adalah permasalahan misalnya kita pada adherence, kepatuhan, tetapi juga ada pada ternyata transport obat ya, seperti penggunaan oksitosin yang ternyata itu suhu tidak stabil membawa dari farmasi ke kamar bersalin dan lain-lain sebagainya itu mempengaruhi efektivitas obat. Nah, di sini nanti kita akan membuka beberapa pertanyaan. Yang pertama yang bertanya justru Dr. Dwirani Amelia. Dr. Lili mau secara langsung atau saya bacakan ini, Dok? So there is a question from Dr. Dwirani Amelia. Actually, she work at Momentum right now. Yes, she's the lead of Momentum project in Indonesia. Her question is about, do you have experience regarding indicators? Indicator mentioned in INEP for me is more like a district level indicators. How about the facility level indicator? Especially when we try to have quality improvement, we probably need a facility level indicators.
Yes, thank you very much. I think that's a very good question. So if you look at that list there, so it's a mix of indicators. Some of them are facility level indicators. Some can be applied at district level. Okay. So I have them in front of me. So for example, cost of death for maternal and for maternal stillbirth and neonatal, you can do that at a facility level. You can do screening for anemia at facility level, management of anemia, vacuum delivery rate, application of Robson's criteria. You can do that at facility level. So a lot of them you can do at facility level. So it's not just at district level, a lot of those indicators. So I think when you grab hold of that publication, you look at that list, you will see that a lot of them you can do at facility level.
Terima kasih ya. Jadi di sini indikator yang utama adalah pada tingkat fasilitas kesehatan. Jadi kalau bisa kami terjemahkan, I try to speak in Indonesia. Ya, kalau di Indonesia tentu kita di fasilitas level kesehatan kita ada beberapa tingkatannya dan di situ tentu ada standar minimal yang harus dipatuhi. Tentunya fasilitas kesehatan di Karyadi minimal atau kita bilang ya standar operating prosedurnya tentu akan berbeda dengan yang akan di tipe C gitu. Tetapi kita sudah memenuhi apa yang diadakan minimal standard procedure. Yeah, in our country because we have so many level of health facility, so it means that we have to identify or we created some minimal standard in the primary health center, and then the level C and the level B and the level E. So that's why after that we recognize what the reality problems in specific facility that should be solved. Yeah. Is there any point yet that you want to point out in this point?
Yeah, so I think it is quite important that there will be so based on what the Ministry of Health expects a different level of care. They define standards at each level, what sort of service should be available, and then to what standard. So for example, maybe in level A, just for example, maybe in level A, only where you can perform cesarean section. So the standards for cesarean section is applicable to level A. Maybe in level C, there is no cesarean section. You cannot apply, it's not, so it has to be appropriate, what is services available at that level. So the standards will apply. And I think it's for everything. If you want to use a health systems approach, for example, you say you expect level C, maybe one facility serves a population of 5,000, and for that we need 10 midwives and 2 doctors. That is a standard. That's the minimum standard that is expected. So in terms of, if I am the health facility manager, I want to know from time to time what proportion of my facility are meeting that standard for the health workforce, for example. Yeah.
Ini ada pertanyaan lagi tidak dari audiens? Ya, silakan Dr. Putri yang kebetulan datang.
Okay, thank you, Dr. Ratna, for the time. How we can advocate government
Thank you, Dr. Ratna, Prof. Charles, for the time. Can you give me tips or something we can do for our regulation? Because to get the standard, maybe we find difficulties because the standard we can approach that from our profession, OBGYN. So how your advice to us for profession to get that standard in government level? Thank you, Prof.
I'm not sure I fully understand.
Untuk mencapai standar minimum, bagaimana caranya supaya di rumah sakit yang levelnya lebih rendah itu bisa sama apa yang bisa kita lakukan untuk yang standar minimal itu bisa tercapai begitu, Bu. Jadi karena seiring pimpinan daerah program, jadi untuk yang standar yang sudah ditetapkan kadang-kadang sulit untuk dicapai. Mungkin caranya mencapai yang standar minimal itu bagaimana caranya, karena seringkali perubahan politik dan program itu yang sering membuat kesulitan.
I just translated ya. Ya. Sebelumnya untuk audiens yang secara online tadi kami sebelumnya minta maaf ya karena ada beberapa gangguan sound system di sini sehingga terdapat keterlambatan dan kita membutuhkan untuk perbaikan. So Prof. Charles, that Dr. Putri stated she asked about how to achieve the minimum standard because we have so many barriers. Yeah, sometimes the minimum standard has been developed, but there is a regulation that could be the main barrier or the bottlenecks to the standard. And Dr. Putri and all of the team that's already attended through this Zoom meeting online, we want to know, can you share experience how to achieve the minimum standard with some kind, maybe, yeah, the bottlenecks in the regulation from our government itself?
Okay, I mean, I can give it a go without a a specific example. So let me go back to my postpartum hemorrhage. Okay, so say WHO has come up with a new guideline and evidence on the use of, say, tranexamic acid for postpartum hemorrhage. The government has signed up to it. They have updated the guideline to say tranexamic acid is one of the drugs to be used. Okay. We know from the evidence that tranexamic acid needs to be used within 3 hours. But they say, tranexamic acid, at the same time, they say tranexamic acid should not be available at the first level of care. So by the time you make a diagnosis of PPH and you refer the woman to the major referral center, maybe it's more than 3 hours. So there's a problem with that. It does not really work. So so how do you identify this bottleneck at this? So this is where the problem is. How do you convince colleagues who are responsible for policy to change this type of thing? So I think the only thing they will listen to is the evidence. What is happening. You can show them from the data. This is the amount of women we are referring. This is the amount of women having blood transfusion. By the time they get to this point of care where we have this drug, it's already more than 3 hours. So they cannot benefit from this. So you use evidence to convince policymakers. That's what can make a difference. Otherwise, it's too difficult to get their attention. You need evidence.
Yeah. So evidence into policy making. Yeah. Okay. Yeah. Is there any question from race? Yeah, Dr. Lily, have 2 questions. Okay. From Dr. Lily again, from Momentum. On the obstetric care model, where is the over medicalized pace interfere? Or is there model considered applied to an ideal condition? Okay, this one.
On the search model, where is it? Oh, okay. Let me explain that again. So in that obstetric transition model, so where they talk about medicalization of birth. So medicalization of birth will mean so pregnancy, it's a physiological process. Ideally, I mean, naturally, whether you interfere or not, the woman will deliver, isn't it? The problem is when there is a problem to know what to do and intervene. So at times, when you talk about medicalization, the intervention we're talking about is some assisted birth. And typically, classical one will be cesarean section. So that's what we mean in this place, cesarean section. So my point is, when we had very few cesarean section, it was associated with a higher maternal mortality ratio. That is because women who needed C-section, maybe because they were obstructed, they were not getting the C-section. If you need a C-section, you need a C-section. There's no other way for an obstructed labor. That uterus will continue to contract until it ruptures. If it ruptures, there's bleeding, there's infection, there's death. But what has happened is that as the practice of cesarean section, the cesarean section rate has increased over the years. This has been associated, amongst other measures, with a reduction in maternal mortality ratio. But in countries where maternal mortality ratio is so low, there's a tendency that we're having too many cesarean sections, and a lot of them may be unnecessary. if you perform unnecessary C-sections, it puts the woman at risk as well. Okay, cesarean section is not without risk. There's a lot of risk for the woman, for a family. It costs money, infection, sepsis, bleeding. So many things can go wrong. Placentation in future, there's a scar on the uterus, abnormally implanted placenta previa, name it. So many things can go wrong. She forms adhesions, fertility in future may be compromised. So cesarean section is a big decision. If it is taken, let it be medically indicated, because overutilization of cesarean section as well is a problem.
Okay, thank you. So likely that cesarean section could be dilemma in this case. Yeah. In developed countries, the incidence of C-section is increased, but the maternal mortality is reduced. But actually, we have also the impact of cesarean section. And in Indonesia right now, we have also the same problem that the incidence of placenta accreta is increased. And it needs more multidisciplinary approach team. And then also facility resources. Yeah, but yeah, there is a challenge, and the best recommendation right now that we have to reduce the incident of C-section. Okay, is there any comment? Okay, Unana.
Good afternoon, Professor. My name is Nana. I would like to ask you, when we are talking about how to do the audit, so we will see at the level of the policymaker, like the government and then also the institution. However, I am interested in knowing whether any pre-hospital factor from the community itself that can be screened before to prevent to reduce the maternal death. Because like you said before that, all right, like anemia or maybe the other factors, it can also play important role to create the maternal death. So I'm thinking about how to empower communities so that they also knowledgeable to also reduce the maternal death. So maybe from the evidence, are there any like the factor from the community so they can reduce the maternal death? Thank you.
Yes, so thank you very much. I think that's a very important question. So I think what we focused about was we kept it quite narrow in terms of how we improve situations at the point of care, which is maybe in the facility. That's where we look at that sort of quality improvement aspect. However, when we have a maternal death or a near miss, it's good that when we do the reviews, we go beyond the facility. So going beyond the facility, looking at what has those factors in the community that may have contributed to the poor outcome is important as well. When you're doing standard-based audits, it's focused at the facility. But then that's why I say we may need to combine. When you do the maternal death reviews, which can be facility-based component and community-based component, meaning that you have to investigate further. So this woman, she may have, her cause of death may be postpartum hemorrhage, with associated, antenatal anemia and poor nutrition, maybe a diagnosis that is there. If you want to investigate that antenatal anemia, you may need to go and understand what is happening at household level, the nutritional status, what is happening at that level. And you may see that this is a pattern across several other women in the community. So once you identify that problem, you need to work with the community, with the right, stakeholders to address that problem. Nutritional work, first folic acid supplementation. There may be other things that are involved here, from infestations and all of those type of things need to be investigated. But yes, community is important, you know, when you're looking at causes of maternal deaths. And, you know, there are standard ways to conduct those community reviews and to work with the community as partners. So you have the patient groups, the women groups, you know, the people who are gatekeepers in the community, to work with them to address some of those issues. Things that are embedded in the community as part of culture, they take a longer time to address. I mean, something like anemia. Anemia can even be linked to, okay, you know what? This person did not have access to antenatal care. And the reason why they didn't have access is because of they need to travel too far, or they have had a bad experience in the facility before. They don't like to see any doctor, midwife. They are taking their chances. So you need to understand what the factors are. But until you talk to people in the community, you will not know. And so you cannot find the solution. So it is important that that aspect of maternal death review is also conducted. Not only the facility one is important. Yeah. I do hope that answers the question. Thank you.
Yeah. Okay, Prof. Charles Ame, I will ask you a question. I'm interested with Wilcox and et al. Findings that they stated about limited evidence of effectiveness of maternal death surveillance and response. Actually, we know the reality, not the reality, the evidence stated about the other evidence or the WHO recommendation. The MPDSR actually as a step point for quality improvement. Yeah. Do you think that the statement limited evidence of effective of MPDSR, or we still cannot find any solution to drive the MPDSR in the field, something like that?
Yeah, so that is why in my slide, I quoted from the same paper. So they had it was a multi-country cluster randomized control trial. And in one arm of the study, you know, they put in like external facilitators. And what the external facilitators did was that they helped improve the objectivity of the reviews, the development of recommendations, and, you know, what specific things that need to go into training, and help oversee some of that specific training. But in those sites, those were the sites where they had reduction in maternal mortality. So my conclusion is that it was all about the objectiveness of the review. If you allow review to be affected by a lot of feelings, emotions, there's blame, you know, shame and all those things, then you miss the point. You do not find exact things that you can improve, you can avoid in future to prevent that death. So at times, if you have somebody who is not involved at all in the management, he has nothing at stake, they can help keep everybody on track. But I am saying that is not mandatory, but this is what has been observed. But if you have good leadership at the facility, they can also do the same thing. So if I am managing a facility-based maternal review and I create an atmosphere that this is collaborative, we are in it together, we want to improve the quality of care, we are not here to blame anybody. We are here to learn from our mistakes and see what we can avoid, what can we avoid in future, what can we do better, so that the next woman who is coming, which can be my sister, can be my friend's mother, we can take care better. So if you create that atmosphere, there's good leadership. So when we finish the review meeting, we don't finish, we go. You say, no, before we go, these cases, what have we learned? Somebody write it down. Okay, we learned that, you know, the reason why there was delay to start the IV fluid or to give the treatment was that the doctor was too busy in another ward attending to emergency. So it may be, the action may be, maybe we need more than one doctor on call. Maybe we need more than one doctor on call. If we need more than one doctor on call, what does it mean? So just imagine in this review meeting, you have somebody representing the hospital administration. The head of the midwife is there. the OBGYN is there and everything. You have identified this as a problem. You have all the heads together in the same room, finding a solution. Say, okay, but maybe we only have few doctors. Okay, instead of putting them 24 hours shift, do we have 2 people every 24 hours? And then we give them 1 extra day off. Do you see, you can come up, if you put heads together, you can come up with solutions. And then you implement and see. But you have now, because you have 2 doctors, you have reduced the treatment delay, which you identified as a team, and you can implement. Okay, the doctor was not on call because he went to his house to sleep because the call duty room the toilet there is out of order. So before they called the doctor to come from his house, it took 1 hour, 30 minutes. No, there was nobody to repair the cervical tear. So by the time the doctor arrived, the woman is in shock. So what is the solution? The solution is not punish the doctor. The doctor is not responsible for the room he's sleeping in the place. So you need to sort out that toilet. So if we all agree, you get the hospital management, you can sort out that toilet in 48 hours. Once there's a will, there's a way. And then from 2 days' time, doctors are sleeping there. You debrief everybody, you will have prevented that problem in future. So if you create that atmosphere with leadership at local level, there's a commitment for quality improvement. There's not a commitment to punish who has done wrong. They're 2 different things entirely. If you do that, you close people off, learning does not take place, improvement does not take place, quality of care will not improve. So once you have the right leadership at that level, you will achieve the same results as an external facilitator. If we go down the route of an external facilitator routinely, you know what it means? It means more money. You have to pay somebody to travel there, you need to pay, which is not sustainable, okay? So, but we can rather focus, say, okay, let's improve the leadership at facility level, the ownership of this and the commitment to bring about change. Yeah.
It's hard. Yeah. Okay, for driving solution that you capture about that we need a hard commitment. Yeah. And there is somebody have to be a timekeeper in the health facility that the maternal debt review has been done. And then what is the timekeeper that we can monitor and supervision the recommendation can be done. And then is there any problems that to be solved during we implement the recommendation? Yeah, okay. Okay, the key point is commitment.
Yeah, so you need commitment. You need commitment. But back in the day when I was senior registrar and I was in charge of the secretariat for the managing the maternal debt reviews in the hospital.
Yeah.
Even though I'm not on call, every morning I start from the wards to collect all the records of all the debts.
Okay.
So I collect it. I organize it. I inform the consultant handling that case. This is what has happened. Who in your team will help to prepare the case? This is the timetable for the presentation. Organize the meeting. During the meeting, you make sure that there's action. This is what needs to be done. By whom, by what time, who else is involved. Then based on that, what we agreed, I will go around and be checking with the people. And then I come back and report to the people to say, yes, we are making progress. We are stuck here. We need more solution. What will we do? So it's not, we put heads together, but there's a commitment to bring about that change. That's the only way it works.
Okay. Yeah. And then it is Prof. Charles Ame, that's the mandatory from Wilcox study, as you said, about external facilitator. And one of my study, when we try to identify what is the challenge of the implementation of maternal audit in Indonesia, is about budgeting. So that's why it is the cost for data collection is higher in Indonesia because we have a multi-referral states. Yeah, when the woman finally die, they come from the hospital A, hospital C, hospital. So so the budget just finished it during data collection, and then the review process it's not scheduled properly, and then after that implementing recommendation is hard because there is no budgeting anymore again. And then one kind of solution about the external facilitator in this case, do you have any prerequisite for external facilitator? And then during facilitating the maternal debt review, what they have to do? It's likely they have a mindset. Yes, even I'm an external facilitator, and when I come to one of the district level maternal debt review or in the other health facility, in my mind that I have to review it based on evidence at the first time, and then the second things that I have to do the review with the implement with the principle of maternal debt review. No blame, no shame. No blame, no shame, no, what's that? Okay. No name, no blame, no shame, prejudice. Yeah. Yeah. We have to create it, the learning environment, and then free blame culture, and all of the things could be a positive atmosphere. Yeah. So what do you think about that?
So I think first of all, an external facilitator should be somebody that has nothing to do with had nothing to do with the management. Is not familiar with the thing, so they can come in with a clear head. I think essentially they just need to help create that positive atmosphere for that review to take place, and to make sure that everybody involved is quite clear what the objective is. We're here to look for how we can avoid the future debts like this. And we want to leave here having some clear actions with timelines, responsibility, who needs to do what to change this situation. And then, where we need any training, it will make sure that, it can guide them to, what is required to address that problem. So it's not all over the place. So it's just sort of that sort of check and balance to help keep things on course. That's what that kind of person helps to do. And the more the person is removed from the process, the theory is that, it's better. It provides more objectivity. But like I said, I think that can still be achieved internally, just based on commitment and good leadership. And that will reduce your costs significantly. Then on the issue of the data, the records, I mean, I think it's a challenge. If you had in countries where they have very good electronic record system, it's all in the system. You move from point A, point B, point C, you put in the number, the name, the date of birth, everything comes up. You want to do a review, you put in the number, the date of birth, it pulls all the information, everything about this person, immunization history, everything, it spit it out for you, you use it. So that's very good. That's electronic system. In the absence of that, I think we need to, first, there's the issue of the paper-based. If you have a culture where people are being defensive, a lot of the paper will disappear. At times it's paper-based, but later on it is scanned and put in an electronic format after some time, and then it is centrally. So some places is like that. So where you have like, there may be a standard, the medical records people, maybe within 1 week of discharge or death, what they do is that they all the records for that patient, they scan it into this electronic system, is available on the server. So that way, if you are conducting the MPDSR in a far place, you can put information in the server and pull up those records. So that is an electronic system, but it's not in real time. It may be delayed, but that's one way. But that is an easier method, because if already you have in a country, like say the health information management system, where they put records, the health record, the key in records, and it goes centrally to the Ministry of Health. It's the same system. You can arrange, you can organize, a module can be the record keeping, but it's a bit retrospective, but it will be there electronically. You just need to expand the servers. So there is a solution. That's an easy solution to the problem. Otherwise, you depend on the paper. So two things with the paper need to be filled accurately. And then you need to be able to collect all the paper that belong to one person together. And that's another problem. Many things get missing. Yeah.
Ya, mungkin ada pertanyaan lagi. Kami ada satu pertanyaan. Oh ya, mengingatkan kembali untuk peserta yang mengikuti online untuk mengisi daftar absensi ya. Nanti dari panitia juga akan mengirimkan sertifikat ya. Okay. Okay. This statement again from Dr. Lily from Momentum. Yeah, she really impressed with your lecture. Very clear example and visible. What remain is our we want to do beyond our might. Great. Thanks, Professor. Thank you. Thank you. Yeah. Yeah.
One of her colleagues, Momentum,
Yeah.
Susan Stolz and Pandora Hadman. She will know the people I'm talking about.
Okay. Dr. Lili masih bergabung nggak ini? Yeah, maybe she has some jobs. Okay.
Sorry.
Yeah.
I'm still here.
Ada
Yes,
pertanyaan lagi di sini?
Susan and Pandora is our colleague. Thank you, Professor.
Kalau tidak ada, mungkin nanti kami bisa menyimpulkan ya. Saya masih memberikan kesempatan. Okay, Prof. Charles, is there any question? I give you one question. What I think is it correct or not? I need I need your correction about it. About quality assurance versus quality improvement in your slide. That you stated about quality assurance is benchmarked against performance. It could be the review in MPDSR, and then quality improvement, you stated about the understanding a process. And then do you think what I try to translate it as the process of the action cycle, the review process, the recommendation and action? No.
So let me clarify that.
Yeah.
So if you are just strictly doing an audit, so you have a checklist to see whether this standard is met, yes or no. So you can end up and say, okay, only X percentage meet the standard. Audit stops there. Quality improvement, on the other hand, you will ask yourself, why we did not meet that? What is wrong in the process of that, meeting that standard, and pinpoint what that is, and then come up with solution. So if you are an external person, you will not understand the process. You need to be part of it to be able to understand what is going on. And then you can come up with solution. And those solutions, once you implement them, it's likely to lead to sustainable change. Audits just on its own is just an exercise. It's incomplete. You need to move to the next to look for the solutions based on your understanding of the process of caregiving. Where are the gaps based on this audit? What improvements can we make? Then you implement the improvements. Maybe we need more training. The medication is in a far place, bring it near. We need more doctors. We need more this, But then because there's a commitment to improvement, there's a tendency at times that you look at the solution so far away. You say, you know what, this is Ministry of Health. We cannot do anything here. The Ministry of Health has to employ 50 more doctors. We cannot do anything here. They need to increase the salary. We need 5 ultrasound. Nothing is going to happen. What solution can you find now here to make it? You will, if you discuss, you can find. There may be few that you cannot find, and you say, okay, this one we need ministry. And then you tell them, this is what we found out. This is what we have done. This is what is left. If we do this one, it will help. This is how we arrive at this. You are more likely to convince them to move in that direction than you go and you say, you know what, all the women are dying. We have done everything. We are okay. You have to do something. It's not true. There is local solution to all of those problems. If we're honest, we'll find those solutions.
Yeah, sometimes in Indonesia, we have a difference, not actually a mindset, but everyone said about audit is the review process, partly. And right now, we try to deliver into response and surveillance. Yeah. Okay, that's today is already 3 p.m. Yeah. Yeah. Thank you, Prof. Charles Ame, and thank you for all the audience that you attended this guest lecture today. Dan di sini nanti tentunya akan menggugah harapan kami akan memperkaya untuk pelaksanaan dari AMPSR yang akan jalan di yang sudah berjalan di Indonesia ya. Jadi di beberapa tempat yaitu sudah melakukan seperti di Provinsi Jawa Tengah sudah cukup aktif untuk sosialisasinya. Dan kebetulan di Jawa Tengah juga Rumah Sakit Dr. Karyadi sebagai model dari pelaksanaan AMPSR di tingkat fasilitas kesehatan. Tentunya acara guest lecture ini akan sangat membantu pelaksanaan AMPSR baik di tingkat wilayah maupun di tingkat fasilitas kesehatan. Karena dengan adanya modeling rumah sakit ini, ada justru kita menemukan suatu titik tolak yang seperti misalnya kita memberikan contoh ya, di sebuah kabupaten bisa menyampaikan bahwa kematian kami 0 atau 1. Dan itu selalu menjadi perhatian di tempat tersebut tidak pernah ada suatu masalah. Nah sekarang kita melihat bagaimana kalau seandainya diadakan quality improvement, salah satu rumah sakit yang menjadi pusat rujukan di kabupaten tersebut. Ternyata di situ ada beberapa kasus kematian ibu, tetapi di luar wilayahnya KTP-nya. Tetapi dan kabupaten ini kesannya mempunyai 0 atau 1 kematian ibu. Sebenarnya rumah sakit di wilayah kabupaten tersebut, dia ada banyak masalah dengan kasus-kasus kematian ibu yang perlu dikaji untuk perbaikan kualitas pelayanan. Jadi tentunya selama ini kita di dalam menjalankan proses kajian audit maternal, proses melaksanakan AMPSR yang terfokus pada permasalahan data kematian ibu per kabupaten, sekarang dengan adanya modeling rumah sakit itu tentunya akan memperkaya atau memperkuat untuk quality improvement pelayanan kesehatan di kabupaten itu sendiri. Terima kasih dan kami ucapkan juga terima kasih ya juga khususnya di sini cukup banyak attendance yang datang ya, many participants from Ministry of Health as like I said you before, Momentum, UNICEF, UNMPA, WHO, and also from all the senior in the universities in Indonesia like Prof. Hakimi and Prof. Aryawan, and all the OBGYN, nursing, and also midwife, and also the programmer who try to strengthen the maternal perinatal death surveillance and response in Indonesia. Kami tutup. Bila taufik wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh.
Recording stopped.
It's okay. It's okay. Thank you for that. That was very interesting and then also insightful lecture. Thank you for Professor Charles and then also Dr. Ratna. And ladies and gentlemen, both from offline
Recording
and
in
online
progress.
venue, thank you for the attendance and then also the participation in this guest lecture. We may meet again in the next lecture. Thank you very much. And wassalamualaikum warahmatullahi wabarakatuh. Thank you. Very interesting.